Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and I'm exactly one half of the Bob and Brad team. And today, my return guest is Cynthia. She's a physician's assistant with Summit Orthopedics. We're a place up in the Twin Cities, actually. They have multiple locations in Minneapolis and St. Paul. And today we're going to talk about, we got three subjects we're really going to talk about. And one is whiplash. The second is cervicogenic headaches, which is neck headaches. And the third is just, regular overall neck pain. And hopefully we can get you some solutions if you have any one of those three. So join us for the program. Welcome back to the program, Cynthia PA-C, who was last time coupled up with Dr. Ekstrom, but this time she's going solo.
Flying solo.
Yeah. Thanks for taking the time and being with us. All right, let's go to just plain old, if there's such a thing as plain old cervical pain. And that can, run a wide range from just cervical stiffness all the way up to radiculopathy and pain going down the arm. Maybe Let's talk a little bit about that. What are some of the common things you see in that range?
Yeah, so we definitely see all of it. Everything from someone presenting, like you said, with a little neck stiffness, and someone presenting with pain and weakness in the arm. And then we've seen everything, even up to the point of cervical myelopathy, so compression of the spinal cord, so weakness, not only in the arms but into the legs and issues like that. So we see the whole gamut.
Yeah, and that'll start affecting your balance and everything. That's a bit of a more serious problem.
Yes.
So let me just ask you on with a cervical disc problem. Do you have a certain approach to your therapist? Still use Robin McKenzie type of approach? Do they do traction? What's on the table for that?
Yeah, so they do use traction. That's one of the things that generally is in our order for cervical radiculopathy or a disc issue. And it's hard because not everyone really tolerates traction, even though mechanically, or kind of the pathophysiology of it, you would assume it would work. You're kind of taking pressure off of that nerve that's getting pinched. But not everyone tolerates it. So our therapists are very good at making sure whatever treatment we've prescribed is also going to work for the patient's tolerability.
Does it get to the point where you actually have them use the unit at home, or is it all done in the clinic?
Yeah, so there's definitely a lot of medical equipment that patients will want to obtain at home, and one of them being, a traction unit. There's, the inflatable traction units.
Right. There's the cheap ones over the door. There's
the over the door, and sometimes I get a little, worried when I have a 70-year-old guy and he's like, "Yeah, I've been hanging upside down." I'm like, I don't know about that.
Right.
But other things like TENS units, those are kind of the main medical equipment that people will want, or Theracanes even.
Oh, sure.
Yeah.
Yep.
You and Brad are familiar with Theracanes.
yeah, exactly. And TENS for our audience is transcutaneous electrical nerve stimulation, and a form of using nerve impulses to try to help gate the pain or stop the pain. It doesn't cure the pain. It helps you manage the pain. Right.
I tell people, I always explain it as the two sticky pads that tingle.
Yeah, right. Fairly benign. You can use on most people. So, but how about as far as what percentage of those people will go on to surgery?
Probably, I'd say maybe close to 20%.
Okay.
of people. Yeah. And I'd have to, I mean, in terms of the span of how long I've been practicing versus, how long Dr. Ekstrom's been practicing, not to say he's old or anything, but I would definitely, some of those percentages even kind of default to him, because he might even have a better, idea of what he's seen, go off to surgical colleagues.
Are they quite often, well, you probably, maybe this isn't a question for you either, but I mean, is it often involve fusion also?
In the neck, I would say a majority of surgeries require fusion.
Gotcha.
In the low back, it can really depend, right? Yep. How many levels they're attacking, is it central? Is it foraminal? It really depends. I think the neck, for the most part, from what I know, it usually requires fusion.
Let's take it back again to the start here. How about medication wise? What might you start with cervical pain?
Yeah. So we always try to start with over the counter.
Gotcha.
Studies show that narcotic opioid medication doesn't really trump over the counter medication.
Sure.
Now that depends on the person, of course, and depends on what's going on. A lot of the times for nerve pain or pain shooting down the arm, that radiculopathy we were talking about, we'll use some of those neuropathic medications. So a lot of people are very familiar with gabapentin. More kind of newer version or sister medication to gabapentin would be Lyrica. So we'll use those. Sometimes some of the antidepressants too can work for neuropathic or nerve pain as well. And then muscle relaxants can be helpful short-term too.
Sure. And what about the length of time for those neuropathic medications? Does it tend to be a fairly long time that you're on those?
There are people that are on them chronically.
That's what I said. Yeah.
Yeah, but sometimes if it's more of an acute issue and we're working through doing the physical therapy, maybe some injections, sometimes we'll try those medications for 3 months or so, and then slowly try to take people off and see if they tolerate being off of them. If they don't, we can kind of titrate them back up and then try again, in another couple months. So they don't have to be a chronic medication. Once you start them, it's not something you're going to have to be on the rest of your life, unless that seems to be what works, what gives you the pain relief you need.
So again, we got traction, we got TENS. I imagine there's some probably manual therapy with that too, like myofascial release and all that.
Yep.
Also applied. So, and always again, posture. I mean,
posture.
So, yeah. So
are you trying to tell me something?
No. I'm not really. I'm the worst one at it. So, anything else that you do want to talk about as far as neck pain or cervical pain?
I think one of the things to point out is, if you're getting weakness in your arms, numbness, tingling, things that have been going on, you can't seek treatment too soon. Having, and that's the same that goes with the whiplash injury that we were talking about. Having someone get their eyes on you, whether it's a physical therapist or a physician or a PA, to really get you at where's your baseline at? Do you have any strength deficits or anything like that to get treatment moving? Because, a disc herniation that injures a nerve that goes, untreated for 4 to 6 weeks and you still have weakness, it's not necessarily 100% that you can get that strength back. So if you ever feel like anything is wrong or need something checked out, it's never too soon.
Yeah, and upon that excellent advice, I think we'll call it to an end, bring it to an end here. I really appreciate you coming by again, Cynthia, and hopefully we'll see you maybe and Dr. Ekstrom again soon. And
yeah.
So
Yeah, we appreciate it. Thanks for having me on.
Yeah, thanks for taking the time.